I think it's so important for people to engage directly at the intersection of innovation, and why I think Compass Project can enable that, because we're not going to be relying on old, outdated data sitting in someone's data warehouse. We're actually talking to real people in real time, right? With continuous listening and empathy, so that we're getting exactly what their lived experience is. And that's the data that should really be driving the decisions.
Welcome to Care More, Be Better, a podcast for people like you who care about the social impact of conscious companies and everyday heroes. Hear inspiring stories from those who put people and planet before profit and personal gain. You'll learn how you can make a difference, vote with your dollars, and get involved today. Here's your host, Corinna Bellizzi.
Hello and welcome to Care More, Be Better, a podcast for social impact and sustainability. Each week, I invite you to care more about a specific issue so that we can create a better world together. Today, the topic is healthcare as it intersects with social and economic equity. We've seen this struggle come squarely into sharp focus as Luigi Mangione stands accused of the murder of United Healthcare's CEO Brian Thompson just in December. We've seen a groundswell of support erupt for him, one that comes from decades-long frustration with our existing for-profit healthcare system and the vast inequities that this system imposes. Now, it looks as though jury nullification may even prevent Luigi Mangione from being convicted, even if he is guilty as charged. Regardless of what your thoughts are about that case, we have to acknowledge that our present system, the American healthcare system, is truly broken. With that acknowledgement, now we can think about how we fix it. What steps should we take? Could technology help? Will AI be part of the answer? How can we get there? Joining me for this discussion is Sheila Phicil. She is a health equity expert and founder of Phicil-itate Change. She holds dual master's degrees in public health and financial economics, is a certified project management professional, and a fellow of the American College of Healthcare Executives. With that, I'm going to welcome her to the stage and we'll get started. Sheila, welcome to the show.
Hi, Corinna. I'm so happy to be here. Thank you.
Now, I understand you've been working at this intersection of healthcare and equity for really your entire career, 15 years now, with institutions including Brigham and Women's Hospital, Dana-Farber Cancer Institute, and also Boston Medical Center. What brought you on this journey?
It's interesting because this journey started well before I was considered a professional, really in my childhood. So I was raised as the firstborn of Haitian immigrants in Orlando, Florida. And as any good immigrants, they really invested a lot in, their education of their children and really pushed us to go into specific fields. Healthcare, being a doctor was one of them. Being an engineer or a lawyer were the other options, or, the fourth option my dad gave me was being a politician. So I did start down the path of becoming a doctor because, I was very much drawn to helping people in that one-on-one interaction of helping them to achieve better health, and was pre-med, had an experience where I went to Haiti as a volunteer, and I got to see firsthand what happens at the intersection of poverty as well as global and public health, and how very well-intentioned and well-resourced interventions can utterly fail to meet people's needs if we're not considering their lived experience. That really took me down the path of becoming a public health professional, and I really dedicated my career to understanding how do we design systems that work well for people? And so that's what's really been core to my journey.
Now, I'm curious because the system in Haiti has to be different than it is here. I'm not sure how. I don't really have any firsthand knowledge of any of that. How would you say it differs from the present American system?
Well, healthcare access is not a right in Haiti. And also there are much more limitations in terms of access to healthcare facilities. There's very limited public hospitals and clinics. A lot of healthcare ecosystem in Haiti is run by NGOs, which is, again, part of the good intent of filling a gap, but also problematic because generally these are resources that are provided for free and can sometimes go away when like grant funding or interest runs out. And there's often not continuity of care. What I saw in my experience was often there was an idea to impose or bring the American healthcare standards into Haitian populations and community is as an intent, again, to like fill a need, and often saw that backfire. And in this specific example, it was a rehab clinic that was providing, access to advanced therapies for people with disabilities, including prosthetics that were like custom fit and wheelchairs and crutches and all the rest. And this was actually prior to the earthquake, where we saw a lot higher like healthcare burden. But what the patients would do after coming in and getting fitted and spending hours in the clinic, they would travel again for days and sometimes hours and return the equipment. And it was only in conversation with them where I realized that these things were not fit for their living conditions because they cross a river and they couldn't get it wet, or they did not have wheelchair accessible ramps where they live. So the wheelchair was completely unusable to them. And so that's often the gaps and the mismatch that we see when you have like NGOs, again, that are well-intentioned trying to deliver a different standard of care.
Right. Well, throwing resources at something and they aren't the right resource for their needs. Yeah. I could see that. So do you believe that our privatized healthcare system in the United States is part of the root cause of our problems here? Or is it something else that perhaps is beneath the veil that we're just not seeing?
It is absolutely part of the problem. But I will also say that this privatized system has yielded tremendous innovation and results as it relates to advanced therapeutics and treatments and different procedures. The US still very much leads in terms of groundbreaking research. And a lot of that has to do with the kind of financial incentives and how things are set up. The problem with that is absolutely great if you can go into a hospital and replace your hip, right? Or get a whole new organ transplanted, or get a therapy that completely cures you from cancer. But if that hospital closes and ceases to exist, then what? And that's what's happening in our healthcare ecosystem. Is there's so much emphasis on profit and driving this very narrow sector of innovation that benefits only a few people, that we ultimately leave our overall infrastructure very vulnerable, and you're seeing hospitals close. So who cares if we have the most advanced therapies, if hospitals are closing and people are going into the emergency room and waiting hours, or if not days, to receive treatment?
Well, I have an infuriating example, which I think many people will relate to. I spent years really believing that having a PPO health plan was the best option, because then I could pick and choose the specialist I wanted to see without having to get a referral from the HMO anytime I went and used my healthcare. But the reality is I very rarely use my healthcare, right? So I'm paying more for a program that doesn't work very well. And so I really would only go for my annual or a checkup. And then it became, a physical every couple of years because I'm really not seeing any real problems. Then I had kids, right? And I was very happy to see that the basics of the hospital care I needed to have those children was all taken care of. But when it came to routine kind of health issues that you might have, like my son had an ear infection, his ear hurt. I went to my provider. They had recently gone through a shift. The family care office that had been privately owned had been bought by another more profit-driven, larger medical company. And I had seen some shifts occur in that health office in that time, and perceived the relationship with my doctor became less. Like they seemed to be getting pressure to spend less time with us. So I would then go to the physician's assistant instead, because they seemed to actually take the time to listen to us, see what our challenges were, and help us on that single visit, rather than having us come back again for another visit that we're again paying a copay for. They're billing for, right? So I was encouraged to come back for things that I probably didn't need to. And, you're having to manage your work schedule, your life schedule. It just seems a little ridiculous. Well, in this particular visit, my son had an issue with his ear, and she said, well, it looks like he has some blockage, some wax in the ear. Do you want me to get that out? And I'm like, well, yeah, like, what do you think? Right. And so she picked up this implement that's just like a little metal tool with a scoop at the end. And she went to his ear and like all of about 3 seconds, scooped it out, and we were on our way. Okay. I did get an antibiotic. Now, surprise to me, a month later, I get a bill in the mail for $160 not covered by my insurance because the doctor picked up this implement for all of 3 seconds and scooped this out of my son's ear. I tried to fight it. I'm like, look, this doesn't make sense. Why was I charged $160? I paid my copay when I came to the office, and now you're billing me more. This would never have happened under the prior management, but was happening now. And so you can see the squeeze coming down on the individual who has healthcare. They have this perception they've paid their copay, they're in the office, things are going to be handled under that copay. But no, then you get the bill. And this happens again and again, and a much larger scale for individuals at times too, because they might have had a treatment that they had to get stitches for and have a perception that this thing is covered, and then suddenly it isn't. Or that they have an issue with their foot that they need to get surgery for. I've recently gone in for a bunionectomy and an ankle ligament repair. I'm in an HMO system now. And as long as I stay within that HMO, almost everything's included and I don't have to pay huge copays. I feel well managed now. But my whole reason for even shifting to that in the beginning was because I felt like I was being nickel and dimed by the PPO that was supposed to be better service, was supposed to have more control over what doctors I might see. But now I'm really being treated like, well, do you have that money? Like, oh, where's your checkbook? Oh, well, we're not going to be able to take care of this unless, and I have insurance supposedly, right?
Mm-hmm.
So I think that this is where frustrations are mounting. You get to a point where not only do you feel like you're operating within the system, but the system isn't taking care of you anymore.
Yeah. And your experience is very common. And in many cases, as you've alluded to, the outcomes are much more tragic because we know that people are often going bankrupt over healthcare bills that they cannot afford, right? And then you also have the other end of the spectrum where services or procedures or life-saving treatments are being denied, right?
Cancer therapies are like one of the big ones, right? Like,
yes. And people are watching their loved ones suffer and have no means of recourse in terms of being able to reverse certain decisions and things like that, right? So, but yes, you're pointing to one of the most common experiences in the healthcare domain that happens in every part of this country.
And it's insidious. It's like, again, something as simple as picking up an implement that is used for 3 seconds. It's like, oh, well, that's billed under this code. And this code means you get charged this much money and that's not covered by your insurance. So you'd better pay it. And they hound you. I mean, I got collections notices in the mail. I just felt like it was a principal issue. I'm like, okay, regardless of the fact that it was $160 and that wasn't going to kill me to pay it, I felt like it was an issue of principle. Like I should not have to pay this. So yes. I did everything I could to fight it to the point where I ended up in collections. I'm like, yes. I'm not going to let this trash my credit.
Well, yes, right. And that's another like very horrific consequence as well, because when people lose access to good credit, that affects their financial well-being. And that in turn affects your healthcare, right? If you're not then able to afford some of the things that you need, like housing and other things, right? I will say this. I spent a significant portion of my career in hospital administration. So I was the person behind the curtain, so to speak, behind the formula, behind the spreadsheet, behind the project management processes, making decisions about what our workflows look like and who got to have access to certain treatments or not. And I was very good at my job, as a lot of people are in this space. And I will tell you that I have made decisions that have enforced inequities in healthcare. And it was a hard reckoning for myself in my career once I realized that the impact that these decisions were having and often disproportionately affecting people of color and marginalized communities who are typically on public insurance. In your conversation, you were talking about HMO and PPOs, which is private insurance and offer much more robust coverage. But we have a significant portion of American families and children who are on public insurance. And the restrictions and the payments are even more drastic and severe, right? So I've been on the other side and I understand why certain decisions are made and the incentives, and for hospitals as well, even those that are not for profit, there is an increasingly high squeeze on efficiency just to be able to manage and keep the lights on. So a lot of what people are experiencing in the doctor's office with visits that are only 20 minutes and having to come back for procedures, for example, is a result of that squeeze. And so hospitals are often serving as pass-through entities, right? The money goes from health insurance to the hospital, who pays a little bit to the doctor, a little bit to the staff, a little bit to the administrative team. But most of the money that flows through the balance sheet of a hospital system or a doctor's office goes to pharmaceutical companies, biotech companies, med tech companies that are worth billions of dollars. So our problem is not a money problem. It is a values problem and an allocation problem. And this is where we really need to innovate to come up with a whole new system and process of how we do this and do this better for everyone.
Yeah. Well, we're getting to the point, and we saw this with COVID, where we had doctors and nurses saying it's not worth the money anymore. I can't do this work. It's like, I'm undervalued. I feel like I'm being told I'm not supposed to spend more than 12 minutes with each patient, not even 20, and all the reasons that they got into healthcare in the first place were just not being respected.
Yes.
And so I think that's a massive issue. This is one of the reasons that nursing and healthcare continues to be a really growing field, because so many people during COVID exited the program altogether. They just said, I'm done. I can't do this anymore. Mm-hmm. And some of that was essentially post-traumatic stress. It's working on the front lines, which is how it came to feel. That's how people described it. My friend who's a nurse and who wrote a book about being a nurse during the COVID pandemic, she writes under the pen name Cassie Alexander so as not to reveal her identity. I've interviewed her on this show, but she also writes like some sexy science fiction novels and things like that. She was a burn unit nurse before the COVID pandemic hit. So she volunteered. She's like, look, I know how to wear all this really restrictive PPE clothing. So sign me up. I can take care of this. Some people had a lot of issues kind of getting used to that level of consistent coverage and having to be masked up all the time. And, like almost hazmat gear, right? In that early phase. And so just the number of failures that she saw in that time, meaning like people that seemed to, in her mind, needlessly die because they didn't have the resources they needed to take care of the patients that were standing in front of them. I mean, we've seen our healthcare system go through incredible stress in the last 5 years, and we've seen an exodus from that profession while the needs continue to increase with an aging population. And boomers are not getting any younger, right? Gen Xers are starting to need the types of services that their parents needed before. And we essentially have to address all of these challenges. It's not just the inequities. So I understand that you're working also within the field of technology, that you're seeking solutions from blockchain and AI-enabled platforms for patients that may be part and parcel to a solution that can help to improve efficiencies without reducing the quality of care that we're seeing and actually standing a chance to help improve that again. How do you think technology is going to change things over the course of the next couple of years?
I think there's a lot of possibility. And I'll start by saying one of my core values that I've kept coming back to throughout my career, something that I learned actually as a public health grad student, is that every system is perfectly designed to produce the results that it gets. So the results that we're seeing, whether it's, the lack of access and coverage to healthcare, as you've mentioned, rising burdens of disease and obesity and other chronic conditions, people opting out of the healthcare workforce altogether, the system is designed to do that. Now, optimistically, I think if it was designed to give this result, then we should be able to redesign it to give us a completely different result, disrupt it, change it, and get it to work for people. And what I've come to fundamentally believe, and I've seen over and over again, is when we center healthcare on the lived experience of patients, when patients are truly the center, that's when we really see really great results. That's when we see people thriving and being able to navigate their health conditions and come out on the other side with their financial well-being as well as their health care, right? Taken care of. So what I'm trying to do through Phicil-itate Change is really bring a revolution to how we think about innovation in healthcare and social innovation broadly. What I often see happening, especially in the era that we live in now, which is quite exciting when you have tools like AI and blockchain that can truly revolutionize things. What I'm often seeing is that people are taking some really great technology and saying, ooh, this can do this and that. Like I can create a chatbot, or I can create some automation that automatically processes claims or makes decisions. And we're applying it to the problem right away, right? With no understanding of, well, what is the problem? Who is facing the problem? Why are they facing the problem? What motivates them? What are the barriers? What is the context? So going back to the example of Haiti, these very well-intentioned medical volunteers brought all this equipment and fancy tech and gear and said, okay, we're going to give you prosthetics and all, wheelchairs and crutches, and had never even known what the living conditions were for these people to even be able to say, like, this is going to help you. At the end of the day, probably a skateboard would have been a better gift to these folks than something that they could not use, which is why we need to center innovation on patients' lived experience, which comes from understanding their story and their data so that you have that context. So what I'm hoping to build and create, one, is a community of people who think like that and want to do that level of innovation and work in healthcare, because it is not simple to do, right?
Mm-hmm.
It is complicated. But now that we have tools like blockchain and AI, it does make it more simple to do that, right? We can turn very complex tasks into and automate them. So I am building a platform called Compass Project, which is really intended to bring patients' stories and their data and ask them like specific questions and get insights on what their experience is with, for example, diabetes. And then use that to generate very specific recommendations on how to design health technology that's meeting that need, and sharing that with a startup or healthcare innovator or a clinical innovator or a biotech firm. And then now the information that they're operating off is real data, right? That's not biased, and it's fresh and it's timely. And on the other side of that, you can create great innovations. But the key for this to work, I believe, is that patients need to retain sovereignty over their data. Your data is you at the end of the day. So the blockchain allows people to keep their data, consent, and give permission in terms of who has access to it, and be compensated when that data is used, and especially if it's used to make profit, right? So that's what I'm hoping to build. I'm seeing a lot of momentum and interest, and I'm very excited about what's possible.
So you have me thinking automatically of the case of Henrietta Lacks when you talk about patient research without compensation. For those that aren't aware of that case, would you mind giving us a quick purview on what that problem is? I mean, I could state it, but you may be more familiar.
Yeah, so in order to develop therapies or treatment before we start testing on people, we have to test on stuff in a lab, right? And a lot of cancer therapy started by testing cancer cells. And there was a Black woman whose cancer cells was extracted from her body, and it turned out that it was easy to replicate and make it in large volumes. So they took from her body, her own data, her own information, her own genetic material, and they used it at mass scale to test different cancer therapies. And it really drove and was a foundational breakthrough in terms of coming up with and creating cancer therapies. Now, she did not know that had happened. Not only did she not know, she was never compensated for all of the breakthroughs in therapies and treatments and money that was made as a result of her genetic material. And that is an example of when people's bodies and their stories and their genetic data is exploited. Now, it led to a lot of good because we came up with therapies, but her family and herself did not benefit from that. And that is absolutely not fair. And with blockchain, we can actually change that. We can make it so that it is absolutely 100% transparent every time someone is accessing your data and what it's being used for.
Well, and this is not the only time in our history that we have, or the medical system, I should say, the research system has exploited African-American women, African-Americans in general. And this has led to an underrepresentation of Black people in medical treatments because we don't test drugs on this important section of the population in many cases. So the drug therapies that are created end up serving white men more than any other class of people, when we might know that the drugs don't work as well in some Asian populations or African American populations. And so one of the things that we've featured on this show, especially when we interviewed Godfrey Coker, who works in that space, is to really increase representation of minority groups in clinical trials so that we see outcomes that can serve a broader scope of human populations in the Americas, and not just those that are, let's just say, socioeconomically privileged and white.
Absolutely. And, that is an excellent point. And we're definitely living in a time where we continue to struggle, right, with the concept of diversity and DEI and its importance. And one of the things that I often try to share as a way of giving people some context and a way to approach this with a little bit of grace is that diversity is something that's actually quite new to us as a human race, right? It's only in the past, like several hundred years, where you have people from different backgrounds and ethnicities and language commingling and coexisting next to each other. It was really the advent of, boats and other things that allow people to migrate and cross oceans that brought us into contact with each other. And of course, there were some often devastating results. But what it did do was it brought a lot of different people into one place, right? Mm-hmm. And we're still learning, what does that look like for men and women to work and live next to each other, for people of different races and ethnicities and background and neurodivergence. And there's no playbook on how to do this. We're really one of the first in human generations to have this much diversity. This is the first time in history where you have up to 5 generations in the workplace even. So age is another factor. Mm-hmm. So I do think that when we talk about DEI and diversity, it's important to frame that context and to allow ourselves to think differently and think outside of the box in terms of how we address those issues and have those hard conversations.
Yeah. Well, and it just makes sense to me to try and create therapies that serve more people than just the few.
Absolutely.
I mean, one key area is you even think about the drugs that serve patients of heart disease, and they were mostly only tested in men. Women tend to have different symptoms, especially prior to menopause. So, how do we then create therapies that can serve that half of the population? And,
Absolutely.
You have other differences between how people of varying genetic backgrounds will respond to treatment. What other therapies are we bringing in? Is there a way to do more therapy that is, let's say, talk oriented and stress management oriented? Can we destigmatize those things more so that people can get the whole person treatments that they need to succeed? Because so often, even, what do they call it? The nocebo effect, the nocebo placebo effect. You don't always need more drugs to get better. Sometimes you need to treat the other areas. It may not just be a physical button or on-off switch that can be assessed with a drug.
Yes. We definitely need more of a holistic approach to our healthcare, because so many issues are, they show up in our mental health, in our spiritual health, and our emotional health before it presents in our bodies. And when we're just treating the symptoms or the appearance of disease, we're really not getting to the root cause and leading people to just a healthier lifestyle in general.
I was hoping you could get a little bit deeper in discussion of your Compass project. I know you've started your YouTube channel, and I watched the quick video that you have up there about it. And as I was absorbing that content, it's only a few minutes. I'll include the link for people so they can go take a peek at that too. It got me to thinking about a book I'm reading for my sustainability education PhD program, which is called Emergent Strategy. And you might be familiar with the book. It's still relatively new.
On my reading list.
I saw your eyebrows climb up. Yes. Yeah. And it's a great book. It's also very different insofar as leadership and research world is concerned, because so often when you read leadership books, it feels like you're reading just a rehashed version of the same thing with like a couple stories thrown in. And here is an author writing a work called Emergent Strategy that is literally bringing in pop culture from her own lived experience and saying, this sci-fi author taught me this thing that I want you to know, or you should really read Dune. Stop everything at this point of the book if you haven't read it and go back and read Herbert's Dune, because there's wisdom to take from these spaces. And sometimes that wisdom is also packaged with entertainment. I wondered if there were any foundational principles that you're drawing into Compass Project, perhaps from your experience in administration, but perhaps from other spaces too.
Well, I definitely draw heavily on my upbringing. One of many things that I learned growing up was the value of community and having people who were just looking out for you and loving on you and, being that social safety net. Growing up, first generation Haitian American, my parents, didn't speak the language and were often very much like struggling to navigate life. And as their eldest daughter, born here and speaking the language, it often fell on me to navigate and help them through different things. And there were definitely times in our lives where we would not have made it if it had not been for a friend, a neighbor, a church member, a family member who just like saw our need and out of the goodness of their heart shared and gave and allowed us to like make it through some hard times. Community is absolutely everything. In it, we find ourselves. In it, we find solutions. And I honestly do believe a lot of the problems that we're facing socially, the answers are already within our communities. The answers are already within our homes. However, communities and individuals are often not empowered to implement their ideas at scale and make it happen. And this is where I think technology, especially AI, starts to level the playing field. Because now you have the tools and you have the data and you have the information to really make an impact and scale. So, but really I never want to lose sight of the fact that community is everything. People connecting with people who have shared experiences and values is really what drives social change.
Yeah, I couldn't agree more on that front. I also think that, the promise of artificial intelligence when it comes to healthcare is really vast. Like the things I've done some reading on have to do with, let's say a doctor is hearing about a bunch of symptoms, but they're having a hard time seeing the connection between them. You feed that information into an AI, and it may be able to help identify what tests should even be run. And it may help identify, an underlying issue that may not have been automatically thought of. But then it's only going to be as powerful as the information we feed it. So then it becomes the responsibility of the healthcare provider to make sure that they are asking the right questions and getting the right detail and encouraging honesty from the patients they serve. Because so often I think we don't want to share about that unhealthy habit or that donut we had for breakfast or whatever it might have been, Oh no, I only have 2 glasses of wine a week when it's really nightly, like.
Yes.
So we also need to destigmatize in a way the habits that patients might have and really come at it from an honest perspective. But I think part of the reason that we withdraw on those things too is fear that we won't get coverage, fear that we'll somehow be, like judged by the doctor or otherwise discounted, because that has so often been the lived experience of people told, oh, well, no, you seem fine. And they know they're not fine, Yeah,
absolutely. Yeah. Data leads to decisions at the end of the day. It's always what has led to decisions. And now that's happening at scale because that data is being fed into AI machines. And to your point, that data is skewed, it's incomplete, it's biased, it's as good as we've got right now. And this is why I think it's so important for people to engage directly at the intersection of innovation. And why I think Compass Project can enable that, because we're not going to be relying on old, outdated data sitting in someone's data warehouse. We're actually talking to real people in real time, right? With continuous listening and empathy, so that we're getting exactly what their lived experience is. And that's the data that should really be driving the decisions.
Yeah. Well, I mean, that's what makes perfect sense to me. Like when you look at it through that lens, you're getting a real picture of what the patient's lived experience is. That includes some things like the symptoms that they might experience, but it also doesn't just limit it as much in that scope. And I think the thing that prevents us from being able to make as much progress as we might in healthcare has also to do with how admin heavy the work is. And administration heavy means man hours heavy. And
Yes.
so if AI can help with that part a bit and start to, I don't know, actually allow the doctors and the nurses and practitioners to spend a little bit more time with the patients, getting the information they need to do their job better, then, the efficiencies go in the right space, as opposed to just saying, oh no, doctor, you spent 16 minutes with that patient. We really need you to get down to 12. Here's how many appointments we want you to serve in a given day. You could spend the 6 extra minutes or 8 extra minutes and get more complete pictures and provide then the services that are actually required and will make a difference, as opposed to, slap a pill on it and come see me in 6 months or something.
Exactly.
Yeah.
Now, the beauty of that, and I'll give you like a quick analogy to bring that home is, the advent of like calculators and, ways of like automating calculations has created huge efficiencies in healthcare. Because when you think about a lot of decisions in healthcare are based on math, right? Taking your weight and dividing it by something, or taking your height and dividing it by something to describe or understand like your dosage and things like that, right? And now a lot of those things, now I just input the information in the system and all of the, dosages are automatically calculated, right? So you don't even have to think about it. Now, the challenge with that is if those formulas are biased, right? And they're leading to bad decisions again, right? But this is again like where the power of AI is. It's going to do what the calculator essentially has done at huge scale. So a lot of the things that have just taken up a lot of time and brain energy don't need to. And where I think this could be actually even more exciting is in the realm of education. We know that doctors and nurses and other healthcare professionals spend a lot of time getting educated and oftentimes coming out on the other side with huge amounts of debt. What if we can shorten the time to education because we can offset, right, some of what needs to happen in the brain to some tool that's reliable and validated, right, and unbiased, and really allow people to focus on that human to human interaction and deepening that connection so that, we can do better healthcare.
Well, sounds to me like another part of that solution has to be elimination of advertising for drugs to every Tom, Dick, and Harry, because
that's a whole nother thing.
I know it's like we could open this Pandora's box, right? Like people going in and asking for some drug to help them lose weight because it's all over the media and everybody's advertising it, or I mean, that's the most popular right now, right? Wegovy or whatever, and it's just like, are we creating more problems here? I think we might be creating more problems here. How do we serve people?
Yeah, but those drugs are an example of incredible innovation, right? That was really meant to solve a very specific problem with folks who have diabetes, right? Mm-hmm. Who, for whatever reason, are not physically able to exercise, right? If you had a leg that was amputated, or you just have mobility issues, or if you have scoliosis, whatever it might be, that's what the drug was initially intended for. And obviously now we found other uses, right? But you're absolutely bringing up an excellent point and something that's, worth thinking about.
Right. Well, doctors spend a lot of time trying to educate themselves on drug treatments and, how they can utilize them, sometimes without understanding contraindications that can come into the fold from either the habits somebody has at home or from other medications they might be taking. They could be in treatment with somebody else for something else.
Absolutely.
More problems can ensue. So, yeah, it blows my mind that there are so many countries around the globe that just don't allow direct-to-consumer advertising by drug companies. And we're just like, here, come on, just give the money to TV and slap a huge disclaimer on the end, including something like, side effects may include development of leukemia, certain like you're like, wait a minute, blood cancer? A side effect of cancer, and this is an approved drug. What's going on here? and it's for rheumatoid arthritis or something like that, Ugh. Yeah, just a little bit infuriating. Well,
it is very telling.
At this point in our conversation, I like to offer my guests an opportunity, and that is simply, if there's a question that I haven't asked that perhaps you wish I had, you could ask and answer that question. Or if you had some closing thoughts you wanted to ensure our audience left today's conversation thinking about, you could share that too.
Yeah, absolutely. If anything that I've shared has resonated with your audience, I would love for folks to engage with me in this process. I'm very much trying to practice what I preach in the sense of developing this platform with people at the center. And to do that, I need to work with people. So I'm looking to speak to and engage with entrepreneurs, clinical innovators, researchers, community leaders who have thoughts or are working on different healthcare innovations and want to work with me in terms of figuring out how to design it better, how to design it with patients at the center, and how to really apply the innovation framework that I have developed so that you're really producing results for people. I'm also looking to talk to patients with lived experiences in different parts of healthcare, starting with diabetes, actually, which we know we have a huge burden of diabetes in this country. So would love to engage with people and communities so that we can begin to understand and collect those stories and the data to really drive more innovation in this space. So if folks are interested in working with me or learning more, I really encourage you to go to my website, Phicil-itate.change.com. And it's Phicil, spelled like my last name with the dash, itate. Change.com. I think that would be a wonderful place to get started, even if you're just looking to stay informed.
Yes. And I will be sure to include direct links to everywhere people can find you with show notes. I also have some friends. I have one friend in particular who is a type 1 diabetic. She's been diabetic since she was, a kid, and has a very long-lived experience of having dealt with that as a result. She's now in her 40s and connected to community too. So I think that could be an interesting introduction for you. And of course, also, I've mentioned Godfrey Coker and his work. I feel like there could be some synergies between you for sure, as he's working to ensure that there's more diversity in clinical trials and working on NSF-funded projects and things along those lines. NIH, rather.
Absolutely.
Yeah. Well, very good. Thank you so much for joining me today. This has been my distinct pleasure.
Thank you, Corinna. This was absolutely fun for me. Thank you.
To find out more about Sheila Phicil and her work in health equity with Phicil-itate Change, visit show notes. You can also go directly to her site, which is Phicil, spelled Phicil -itate, ITATE, change.com. You can also simply visit show notes. There you will also find a direct link to our blog page for this episode. It includes the video version of this podcast, complete transcripts, and links to the resources we discussed today, as well as that prior episode with Godfrey Coker. While you visit our blog page, I encourage you to join our newsletter. This way you'll be the first to find out about new episodes. Plus, for every new subscriber to our particular newsletter, we are going to plant a tree through our partnership with Forest Planet. Thank you, listeners and watchers, now and always, for being a part of this pod and this community, because together we really can do so much more. We can care more, we can be better, and we can even remake our healthcare system into something that serves all people, not just the wealthy few with, quote, good insurance.
Thanks for listening to Care More, Be Better, a podcast for social good. To make sure you never miss an episode, subscribe, rate, and review wherever you listen to podcasts, and share with your friends to help us reach more people and spread more social good.